there's some ongoing trials that are looking at copanlisib. They look at probably different designs. What is your knowledge about that?
Yeah, so there are a number of randomized studies which are trying to combine copanlisib with different agents and to evaluate the activity of copanlisib in this setting. Kronos 3 study randomizes patients between rituximab alone or rituximab plus copanlisib, and it's a very interesting study in a relapsed refractory setting. And hopefully we'll learn the value of a combination in this setting. Kronos 4 is also a very interesting design because it builds on this concept of adding targeted agent to chemotherapy. And it's using actually investigator choice. So it's either BR plus copanlisib or R-CHOP plus copanlisib versus BR or R-CHOP, depending on the pattern of practice. And I think this study will be very interesting to watch. I'll be curious to know over time what toxicities we'll see this combination, hopefully very limited. But I think adding, in general, targeted agents to chemotherapy, chemoimmunotherapy backbone makes a lot of sense, and I'm keen to see the result of this study.
So there are a couple other PI3 kinase inhibitors in development. One is duvelisib, which is a delta inhibitor, also has inhibition of the gamma isoform that may broaden its applicability to diseases outside, say, follicular lymphoma and chronic lymphocytic leukemia. There have been, the pivotal trial has been completed, which is in chronic lymphocytic leukemia, but there was also the Dynamo study that showed similar response rates and duration of remissions of what we've seen with the other PI3 kinase inhibitors. So I think there's lots happening in the PI3 kinase space, and it's going to be interesting to see how this all sorts out. Of course, there's also the umbralisib, which maybe has a totally different safety profile, and that's also going to be interesting whether we see the same efficacy with that drug.
Yeah, it's really exciting to see that we're able to now capitalize on years of basic research which was done in the importance of PI3 kinase pathway in lymphoma.
I think it's just going to, it's wonderful to have all these choices, right? But that does complicate just some very simple decision making about what is the best sequence. So Loretta, look into your crystal ball and tell us how we're going to be doing this in the years to come.
So I think efficacy drives a lot of our decisions, but we can't forget about toxicity, right? And I think as oncologists who've had many decades of experience with chemotherapy, we're all quite comfortable with the safety profile of chemotherapy, and we're also quite comfortable choosing chemotherapy based on patient characteristics. Again, with the addition of new CD20 antibodies, maybe we're learning a little bit more. With the novel agents, I would say we have just less experience, and so as we have longer duration of therapy on these studies, some of the toxicity profiles tend to play out where there might be some differentiated toxicity. I think that will factor into some of our treatment decisions. Before the era of the checkpoint inhibitors, I can tell you we were all very nervous about colitis, pneumonitis, transaminitis, and not that we're not nervous about it anymore, but I think we have more experience in terms of how to identify it and how to manage it across some of these agents. But I still think that the goals of care are to provide patients a durable remission without impacting their quality of life. And how you get there, I think, is still going to be individualized. What we're missing, and we haven't mentioned today, are biomarkers that will help us choose therapy given the biology of the tumor. And I just think we're not there yet.
What about, you've brought up some of the toxicity issues that we see with some of the different drugs. I think Anas talked a little bit about some of this, such as the hyperglycemia and hypertension. For the most part, it sounds like these things are manageable with copanlisib. And does that really affect how you select any of these therapies, Anas?
No, these are on-target effects, so these are predictable. Actually, as you said, they're both transient. If you don't check the glucose level of these patients, you would never probably notice it. They're just checked because in a clinical trial. So it happened like they peak and then they go down within 4 hours or so, and the blood pressure also would normalize within a few hours. So this is on-target effect, and they do not require intervention. That's the most important thing. You don't want to see someone whose glucose level goes, let's say, to 500 and give them insulin. This is exactly what you don't want to do because they may end up having hypoglycemia. So it's awareness. As Loretta said, you have to be aware of these side effects, how to manage them. No need to intervene most of the times. So they will not affect my decision because I know how to deal with them.
I want to add one more thing to the sequencing component. One emerging trend that I'm seeing is the re-exposure to chemotherapy. For instance, patients get bendamustine rituximab in front line, and then they get bendamustine and a CD20 antibody in second line. With the availability of these novel agents, I struggle with that decision and who is appropriate for that. And again, I think there are probably a number of other options that may be better than re-challenging with bendamustine.
I worry about the effect on stem cells with bendamustine. It feels like going back to the fludarabine days and damage to the stem cell compartment and the cumulative toxicity that it can occur. And I think that's a good rationale for hopefully moving on to a newer and better agent.